Hello, and welcome to this presentation on fetal arrhythmias, a focus on prenatal ultrasound. My name is Jamie Meck, and I'm one of the Fetal Heart Program Sonographer Coordinators at the Center for Advanced Fetal Care. This is a two-part presentation that was prepared with Lindsay Seeger, the other Fetal Heart Program Sonographer Coordinator, and Dr. Shifa Turan, Director of the Fetal Heart Program. This is part one of fetal arrhythmias, which we will review the normal conduction system and how to obtain ultrasound images. We will also go into ectopic arrhythmias. This will help us set the foundation for assessing complex arrhythmias, which we will discuss in part two session that will be given by Lindsay Seeger. Okay, so now let's start with the basics. What is a fetal arrhythmia? A fetal arrhythmia is any fetal heart rhythm outside of normal range, 110 to 180 beats per minute, and or without sinus rhythm. However, recent studies suggest that persistent fetal heart rate that's less than the third percentile for gestational age is actually more sensitive for a bradyarrhythmia than the standard 110 beats per minute. And that is shown here in the graph. So at 7 weeks in the first trimester, we have 154 beats per minute or less would be considered bradycardia. At 20 weeks in the second trimester, 138 or less. And then at 37 weeks, we have 129 beats per minute or less would be considered bradycardia. But I do want to go back to the word persistent here. So you do want to note if it's throughout the entire exam or if it's only just a few moments long, because fetal heart rate can drop. And then once you roll mom on her side, the fetal heart rate can go back up. So you do just want to note how long the fetal heart rate stays less than the third percentile throughout the exam. Sinus rhythm is achieved by electrical signals moving through the normal conduction system. So it is a one-to-one conduction, meaning that there's one atrial contraction to one ventricular contraction. And also the AV interval is shorter than the VA interval, meaning that the atrial to ventricular contraction time is shorter than the ventricular to atrial contraction time. Which makes sense because in the right atrium we have the SA node that travels to the AV node, giving us our atrial contraction. And then from our AV node, going down to the AV bundle and out to the right and left bundle branches, which gives us our ventricular contractions. That's obviously going to take a longer time frame than just from the atrial. So the key to assessing fetal heart rhythm is determining the relationship between the atria and ventricles, which is what this beginning portion of the presentation is going to go over. Okay, so now exactly what are we assessing? So first let's start off by looking at the normal anatomy and physiology of the fetal heart. So the fetal conduction system starts at the SA node that's located in the upper right atrium. This is known as the pacemaker of the heart. Next, the signal will travel to the AV node that's located at the bottom of the interatrial septum. This is considered the gatekeeper. From there, the signal will travel to the AV bundle down through the interventricular septum. This is located at the top of the ventricular septum and helps carry signal from the AV node to the myocardium of the ventricles. From there, the signal travels to the right and left bundle branches of the ventricular myocardium. So further talking about the conduction system, we know that the EKG is the gold standard to directly assess the electrical signals, which is made up of the P wave, the QRS complex, as well as the T wave. And over here you can see the heart and its contractions in correlation with the electrical signals. So ultrasound is an indirect assessment that can be achieved by mechanical events or contractions that's associated with the electrical signal, since ultrasound cannot directly assess the electrical signals. Now, to compare both the ultrasound to the EKG, I put an image of the inflow, outflow. So on top here we have our mitral inflow, to our aortic outflow, which is showing us our mechanical contractions. And then down below we have our standard EKG that shows the electrical impulses. So first we have our A wave that shows us our atrial contraction. So the A wave is represented by the beginning of atrial contraction, which is denoted here. And it also correlates with the P wave of the EKG, which also is the atrial contraction. Then we have our outflow, which represents the ventricular contraction. This correlates with the QRS complex that is shown by the orange arrows. This also looks for the ventricular contraction on the EKG. And then to measure the interval, we have the AV interval measuring the beginning of atrial to the beginning of ventricular contraction, which is the same as the PR interval on the EKG, measuring the time interval from the start of the P wave to the start of the QRS complex. So you can really see how to correlate the two together just by taking a look at the ultrasound contractions versus the EKG electrical impulses. So what do we want to measure with ultrasound? First, you can start out by looking at the atrial to atrial interval, which shows you the atrial rate. Then you're going to look at the V to V interval, which is the ventricular rate. And then the AV interval, or the PR interval that we had just spoken about, shows us the time of the onset of atrial contraction to the onset of ventricular contraction. And then vice versa, we can measure the VA interval, which shows us the time from the onset of ventricular contraction to the onset of atrial contraction. As a fetal sonographer, I know that fetal arrhythmias can be quite daunting and overwhelming at times, so I made this slide to kind of help break down as to what you should do while you're actively scanning a fetus that you see has a fetal arrhythmia. So step by step, ask yourself, step 1, what is the fetal heart rate? Is it bradycardia, or less than the 3rd percentile for gestational age? Is it normal, or is it tachycardia, or greater than the 180 beats per minute? Step 2, what is the AV relationship? Is it a 1-to-1 conduction? Are there more atrial contractions to ventricular contractions, or are there more ventricular contractions to atrial contractions? So step 2, you really want to just look at how many contractions for each atria and each ventricle. And then step 3, you're going to want to compare the two. So this is when you're going to get your A to V and V to A intervals. Is the ventricular to atrial contraction longer time interval than the atrial to ventricular contraction? Or is the atrial ventricular contraction time interval longer than the ventricular to atrial contraction? This step 3 is actually extremely important for brady and tachycardia, which we will go into in the second part of this presentation. So now how can we evaluate the fetal conduction system by ultrasound? So we have our two major categories here. The first one is going to assess the overall rate, which includes 2D ultrasound imaging, as well as the umbilical artery, Doppler. Then you can assess the AV relationship by looking at M mode, Inflow, Outflow Doppler, and also looking at the parallel artery and vein Doppler assessment to compare the AV relationship. So to assess the overall rate, we have our 2D imaging. So our 2D imaging helps us categorize, assess the myocardium, and identify any structural anomalies. So first, visually categorize the arrhythmia. Is it an ectopic? Is it brady? Is it tachy? Just visually look at the heart and kind of categorize it from there. Also look for any signs of inflammation or non-compaction that can affect the function of the heart. And identify or exclude causation by a structural anomaly. What can be causing this arrhythmia? Then we also have our umbilical artery Doppler assessment that looks at the overall ventricular rate. It is a quick assessment to get an idea of the type of fetal arrhythmia. It is important for a broad fetal circulation and risk for high drops assessment. And it also can be used to count true beats per minute when the heart rate is irregular. Sometimes when you're just looking at the 2D heart imaging, it is hard to count the true beats per minute because sometimes it can be irregular. So that's when you're really going to take a look at your umbilical artery Doppler and count how many ventricular contractions in a minute and get that ventricular rate. So now taking a look at the AV relationship by placing the M mode cursor through both atrium and the ventricle. So you can see that here to the right, so you have your M mode cursor that's going directly down, and it is looking, it's cutting through the right atrium, and then also it's cutting through the left ventricle. And from there, you can look at the M mode, and you can look at the relationship between the atrial contraction to the ventricular contraction. So we have the atrial contraction, which is on top here, followed by a ventricular contraction. Then we have the atrial contraction, followed by another ventricular contraction, and so on and so forth. So this is going to give us a 1-to-1 conduction, meaning that there's one atrial contraction to one ventricular contraction, which is normal sinus rhythm. However, there are many limitations that go along with M mode, unfortunately. We have chest motion, so fetal breathing. So the M mode cursor basically just looks for motion. So if you're cutting through, the chest, so the M mode cursor is going straight down here, you're also going to pick up motion from fetal practice breathing, which is going to be the bright line up here, which can kind of skewer your M mode measurements here. Also, continuous fetal movements, kind of the same thing as fetal breathing. Angle in which the M mode is placed or the fetal position can be quite difficult at times. Hydropic fetuses with cardiac contractile dysfunction, and difficulty visualizing the beginning of each contraction. However, you can utilize the AMM mode, which is the anatomic M mode, to help isolate the atrium and ventricle. As you can see here, this is more of a subcostal view. So this red M mode cursor is cutting through the ventricle, and the green is cutting through the atrias. So red here correlates with red over here on the M mode, and same thing with the green correlates with the atrial contractions at the bottom here of the dual screen. So at top you can measure your ventricular contraction, and then on bottom here your atrial contraction, and that's noted with the 154 beats per minute. Also, that is a 1-to-1 contraction, which is normal conduction system. So I do find pros and cons of this dual screen. I do like how you can really get a good look at the beginning of each contraction because you are going through the thickest part of the walls here. But it is harder to visually assess the atrial to ventricular just by looking at it because it is just relatively far away from each other on the dual screen. Whereas up here on just the regular M mode, it's almost right next to each other, so it's a little bit easier to assess. So for the dual screen, you're really just relying more on the numbers here. So to further assess M mode, I put the same exact images side by side. And I do want to talk about the difference in measurements that we want to take a look at. So first, again, we have our M mode cursor that's being placed to the right atrium and then through the left ventricle. So the cursor is first hitting the chest wall that is noted over here. So you see how it's bright right here? That correlates with the movement of the chest wall. And then the cursor is going to go through the right atrium, which is shown here by the M mode, and then the left ventricle, which is shown right down below to give us the ventricular rate. So this one you can count how many atrial contractions to how many ventricular contractions to really get the conduction. So this is a 1-to-1 conduction, meaning that there's one atrial contraction to one ventricular contraction. Then the atrial contraction to ventricular contraction. So this you're really looking at how many contractions compared to each other. Then moving on to the right, of course, this is the same exact image, but here we're going to look at the VA and AV time intervals instead of just the contractions here. So first, again, we have our atrial on top here. You're going to measure the beginning of your atrial contraction to the beginning of your ventricular contraction. To give you the first numbers up here, which is 0.130 seconds. And then you're going to measure your ventricular contraction to the beginning of your atrial contraction. And that's shown here by the second number, which is 0.340 seconds. So you can see that the ventricular to atrial time interval is longer than the atrial to ventricular time interval, which is normal. Also, just, a helpful tip, for just the standard M mode, you do want to get a nice 45-degree angle of the heart. That way the cursor is cutting through the thickest part of the wall, especially in the ventricular wall down here because it is on the posterior side. And then you also can reduce your sweep speed to 1 or 2 to optimize the visualization of each contraction. So you're going to make these a little bit smaller here, but you are going to be able to see the beginning of each contraction better than if you increase your sweep speed. Now, another way to assess the AV relationship is by looking at the inflow, outflow Doppler assessment. So doing this, you want to align your Doppler gate over the mitral valve and the aortic valve, the same as you would as a PR interval or a time indice. So you can see over to the right here that the sample gate, and you want to make sure your sample gate is wide enough to catch the mitral valve and the aortic valve that sits right in the middle there. So you want to clearly see the beginning of atrial contraction to the beginning of ventricular contraction to assess the AV and VA intervals. So first we have our A to V. So you're looking at the beginning of your atrial contraction, which is the first red line, followed by the beginning of your ventricular contraction. So that will give you the AV time interval. And then vice versa, we can look at the VA time interval, beginning of the ventricular contraction to the beginning of atrial contraction. And these measurements are noted at the top right corner here, so you can also clearly see that the VA interval is longer than the AV interval, which is normal. However, this may be difficult to assess when the great artery relationship is abnormal, like TGA, or another example would be hypoplastic left heart, or even in the presence of AV valve regurgitation. Always remember to increase your wall filter to 120 Hertz. The heart is beating fast, and you want your Doppler to clearly assess the contractions. So by increasing your wall filter, you'll really be able to see the contractions, especially the atrial contractions, because they seem to be a bit harder to pick up. So just remember to do that. So we do have additional options for assessing the AV relationship by taking a look at the parallel artery and veins. So first here we have our pulmonary artery and pulmonary vein that you can achieve by taking a look at your branching view or your 4-chamber heart view. This one is going to be the 4-chamber heart view that the sample gate is placed over the pulmonary artery and pulmonary vein there. And you can also see the VA to AV relationship, showing that the VA interval is longer than the AV interval. You can also take a look at the transverse isthmus and innominate vein that you can look at in the 3-vessel view. So again, you want to open your sample gate wide enough to really encompass both the innominate vein as well as the isthmus, showing us the atrial contractions to ventricular contractions. And then in the event that there is an interrupted IVC with a zygous continuation, you can open your sample gate wide enough in the coronal view to really take a look at the aorta and the zygous vein relationship. And last but not least, you can also take a look at the renal artery and renal vein relationship. This one is helpful because you can usually get this image in any fetal position. However, this is not my favorite because of the relative distance from the heart. The signal isn't quite as strong as if you were doing the inflow outflow directly of the heart. So the signal does get a little bit lost the farther along you get, farther from the heart you get. So this is, these are additional options that you should be getting used to doing. That way, in case you cannot get your inflow outflow or you cannot properly assess by using M mode, you do have various options in your toolbox to really look at the relationship. So to summarize everything we had just talked about and to put it into our daily ultrasound scanning routine, the arrhythmia protocol, first you're going to follow the routine echo protocol for 2D imaging, just straightforward. Then you're going to take a look at your umbilical artery Doppler assessment to really count how many true beats there are per minute, and remember to decrease your sweep speed to 1. And then M-mode assessment, showing the MO cursor being placed through the atrium and the ventricle. Your inflow-outflow Doppler assessment, and then try to get at least one parallel artery and vein Doppler assessment as well. So you're going to measure all intervals on at least 2 modalities, meaning M mode and Doppler assessment. So you're going to get your heart rate, which is your A to A or your V to V, showing your atrial contractions and your ventricular contractions. And then the relationship between the two, the A to V time interval and the V to A time interval. So now moving on to fetal arrhythmias. So what causes fetal arrhythmias? So I broke this down into 4 different subcategories. We have the structural defects that include Epstein's, left atrial isomerism, pulmonary atresia, corrected TGA, prominent foramen ovale. And then we have our autoimmune diseases or viral infections, the most common being SSA, SSB positive antibodies. Then the inherited channelopathies, we're going to focus on long QT syndrome in the second part of this presentation. And then of course we have our maternal medications and or diet, just like our caffeine intake or beta blockers that mom take to help with hypertension. So because of the causation of fetal arrhythmias that we had just discussed on the prior slide, it is important to obtain accurate and inclusive family history. History in the family, like recurrent losses or sudden death in the family, can be a clue for long QT syndrome. In our department, we have our wonderful genetic counselors that sit down one-on-one with the patients, go through a thorough history. They can really pick up on red flags that I might not be able to pick up on as a sonographer as I'm actively scanning the fetal heart. So utilizing the department's resources to really gain an accurate picture of what we're dealing with here. And then the first line of defense is usually the SSA, SSB positive antibodies, which is a relatively easy blood draw that we'll get from mom. Maternal affections, again, another blood draw that is easy that we can do. Maternal fetal thyroid stimulating hormone levels. This would be another blood draw that we can do. And this one is actually really important with moms who have hyperthyroidism because the blood will show us if moms have thyroid stimulating immunoglobulin or TRAB antibodies in order to exclude transplacental fetal hyperthyroidism that can cause fetal arrhythmias. And then lastly, we have the maternal medications or maternal diet, just like caffeine intake or beta blockers for hypertension. And now moving on to the types of fetal arrhythmias. But first I want to discuss the difference between transient versus sustained. Sustained arrhythmias are present more than 50% of the exam time, whereas transient, they kind of come and go throughout the exam, but are not long and sustained throughout the entire exam. So first category, we have our ectopic arrhythmias, which include premature atrial contractions, or PACs, and premature ventricular contractions, or PVCs. And this incorporates 85% of all fetal arrhythmias, so this is one of the more common fetal arrhythmias that we see prenatally. Then we have our tachyarrhythmia, which is our SVT, atrial flutter, sinus tachycardia, ventricular tachycardia, and these comprise up to 15% of all fetal arrhythmias, so much less common than the 85% of the ectopic arrhythmias. But even less common, we have our bradyarrhythmias, which include heart block, sinus bradycardia, sustained atrial bigeminy, which make up 3% of all fetal arrhythmias. So bradyarrhythmia is rare to see prenatally. So for this part one of the presentation, we're really going to be focusing on ectopic arrhythmias. So we're going to be taking a look at PACs and PVCs in good detail. So PACs, or premature atrial contractions, are far more common than PVCs, about 10 to 1. There is an increased risk to develop SVT in about 10% of the cases, which is why it is important to do weekly auscultations of the heart rate to make sure that SVT does not develop. Usually doesn't require antiarrhythmic therapy. And then just as a side note, we do have extrasystole, which bigeminy, trigeminy, and quadgeminy. So bigeminy follows every sinus beat, trigeminy follows every third beat, and quadgeminy follows every fourth beat. So to start out with ectopic arrhythmias, we are going to review premature ventricular contractions, or PVCs. PVCs originate in the His-Purkinje system. So you can see over on the right here in the diagram, right here where the AV bundle is, or the His-Purkinje system, it lies at the very top of the interventricular septum here. They are relatively uncommon in fetal life. They usually accompany comorbidities such as AV block, ventricular dysfunction, cardiomyopathy, myocarditis, long QT syndrome, and SSA, SSB positive antibodies. Anything that really will disrupt the AV bundle or His-Purkinje system here. So here we have our Doppler assessment of aorta and SVC. So here we have our normal atrial contraction, followed by a normal ventricular contraction. And then we have a quick atrial contraction, followed by the premature ventricular contraction. And you can note that the atrial contraction and the premature ventricular contraction sit right next to each other here. And then we're going back to normal sinus rhythm of atrial contraction, followed by the normal ventricular contraction. Then that early atrial contraction, followed by that premature ventricular contraction. Again, note how close they are together here, and so on and so forth here. Another example of PVCs, we have our M-mode assessment. So you can see here we have an atrial contraction, followed by a normal ventricular contraction. Then we have our premature ventricular contraction, and then our atrial contraction, ventricular contraction, premature ventricular contraction. You can see that the atrial contraction sits very close to the premature ventricular contraction, similar to what we are seeing right here on the Doppler assessment. It is important to do weekly auscultation assessment of the heart because, like I said in the earlier slide, there is a 10% risk of developing SVT, so it is important to monitor closely. So now moving on from our premature ventricular contractions, we are going to talk about premature atrial contractions, which is another category of ectopic arrhythmias. So PACs are one of the most common fetal arrhythmias that we see in fetal life. They are usually benign and commonly resolve after birth. Again, they usually do not require antiarrhythmic medications. PACs can either be conducted or non-conducted, and both can be seen on the same exam. And we will further talk about the difference between conducted PACs versus non-conducted PACs in a moment. But some causes of PACs include prolapse foramen ovale, meaning that the foramen ovale is hitting the atrial wall, causing the PAC, maternal diet, such as caffeine intake, tumors, congenital cardiac anomalies, for example, Epstein anomaly. Anything that affects that right atrium of the heart can affect that SA node and in turn cause the PACs. And then our favorite is idiopathic PACs that kind of come and go throughout the exam and for follow-up exams, but it is still important to do that weekly auscultation of the heart rate just to make sure that the fetus does not develop SVT. Now to talk about conducted PACs. Conducted premature atrial contractions is an extra beat in late systole, which causes advanced ventricular beat. So as you can see here on the Doppler assessment, we have our atrial contraction followed by the ventricular contraction. And then we have our atrial contraction followed by the normal ventricular contraction. Then we have an extra atrial contraction here followed by the ventricular contraction. And now we're going back to normal sinus rhythm of the atrial contraction to the ventricular contraction. So I kind of broke it down here for you. So we have A to V, then we have a PAC followed by the ventricular contraction, then back to normal sinus rhythm of A to V, and then A to V. And here's another example of conducted PACs. So you can see here that there is that extra ventricular contraction here. And now our non-conducted PACs or blocked PACs. This occurs when the AV node has not had time to recover and cannot conduct the electrical impulse to the ventricle. So there's an extra beat in early systole compared to the conducted PACs that happens in late systole. So this has a missing ventricular contraction or a pause between atrial contractions. And you can see here where the red circle is that there is that missing ventricular contraction. So we have our PAC here with our absent ventricular contraction followed by a normal atrial contraction and then a normal ventricular contraction, atrial contraction, ventricular, and so on and so forth here. And then another example of non-conducted PAC. We can see here on the M mode assessment. So again, I broke it down here for you. So we have our atrial contraction followed by our ventricular contraction. So atrial followed by ventricular, atrial, ventricular, atrial, ventricular, and then we have a PAC here that is not followed by a ventricular contraction. So blocked atrial bigeminy is another example of non-conducted PACs. So BAB occurs after every other atrial beat. That is a PAC, which is not conducted to the ventricles. So there is a 2-to-1 conduction, meaning that there are 2 atrial contractions to 1 ventricular contraction. They're usually almost always benign and usually resolve after birth or spontaneously in utero. Here's an example of blocked atrial bigeminy. So we have our atrial contraction followed by our normal ventricular contraction, our premature atrial contraction that is not conducted to the ventricles, so there is an absent ventricular contraction, Then we have our normal atrial contraction, normal ventricular contraction, PAC, that is not conducted to the ventricle. So the atrial rate is variable, meaning that the sinus beat to the PAC will be shorter compared to the PAC to the sinus beat, which will be longer, meaning that the sinus beat to the PAC will be shorter, so this will be a shorter time interval, compared to the PAC to the normal sinus beat of the atrial contraction, so this will be longer. So a shorter time interval and then a longer time interval. So this is variable on the atrial rate. However, this can be confused with second degree or third degree heart block due to the ventricular bradycardia. So if you had just measured the ventricular contraction to the next ventricular contraction, this would represent ventricular bradycardia. So it is important to distinguish the difference between VABs versus heart block, and we will further go into that in the second part of this presentation. And some examples of our premature atrial contractions. We have on the right here our M-mode assessment. So you can see at the top here that the M-mode cursor is cutting through that atria as well as the ventricle. So the atria we have on top here, and then the ventricle on the bottom. So denoted with our arrows here, I just broke it down. So we have our PAC that is non-conducted to the ventricle. So we have an absent ventricular contraction. So we have the PAC, absent ventricular contraction, followed by the normal atrial contraction, normal ventricular contraction, normal atrial contraction, ventricular contraction, and then we have a premature atrial contraction that is conducted to the ventricle, so there is a ventricular contraction, and then back to our normal sinus rhythm of atrial contraction to the ventricular contraction. So you can see down here that there can be a non-conducted PAC and conducted PAC, all within the same time frame here of the M mode. And here's another example. This is a clip of PAC, and if you look closely, you can see that there is the foramen ovale that is hitting the atrial wall here, causing the premature atrial contractions. So more examples of our premature atrial contractions. We have our inflow, outflow Doppler assessment of our PR interval, or the mitral valve and aortic valve that you can see here, noted by the sample gate. So as circled, this is our PAC that is actually non-conducted to the ventricle. So you can see we have our, I'm just going to start here. We have our atrial contraction, followed by the ventricular contraction, atrial contraction, ventricular contraction, atrial contraction, ventricular contraction, atrial contraction that is not conducted to the ventricle, so we have a missing ventricular contraction, then back to our atrial contraction, followed by the ventricular contraction. So here we have a non-conducted PAC. And this is an example of ductus venosus assessment. So you can see here that atrial ectopy has effects on the venous system. So the atrial contraction is reversed here in the ductus venosus, which is a common finding to see during the PAC. And I wanted to include this slide just to show you the difference between umbilical artery Doppler assessment from the premature atrial contractions versus the premature ventricular contractions. So on top here we have our PAC, and then on bottom we have our PVC. And you can see the difference with the peak systolic, how with the PAC it's a little bit more peaky here, versus the PVC that's a little bit more rounded here. So you can kind of see the difference between the PACs and PVCs in the umbilical artery Doppler assessment as well. Thank you for listening to this part 1 of assessing fetal arrhythmias, looking at the normal conduction system and ectopic arrhythmias. In part 2 session, we will be assessing fetal tachyarrhythmias and bradyarrhythmias, which will be given by Lindsay Seeger, and it is available to view on YouTube as well. Thank you.